Hi, everyone. Welcome to Texas Primary Care Consortium's monthly Monday Primary Care Talks. My name is Nishi Singhal. I'm the program officer with the consortium. These monthly Monday Primary Care Talks are dedicated to interviewing guest speakers from across Texas, covering a wide range of primary care topics. Each month, we will bring you, and we are bringing you, informative episodes as your go-to resource, all things primary care. So today we have Diane Arms. Diane Arms is the Director of Community Behavioral Health at the Council on Recovery. She has dedicated her career to serving the Latino population in the health field, including mental health and substance abuse. Diane has previously served as the Director of Health Integration at Avenue 360 Health and Wellness, Director of Prevention and Counseling at the Association for Advancement of Mexican Americans, and with the Harris County Healthcare Alliance as Program Manager, facilitating leadership meetings amongst local FQHCs to proactively identify, address, and resolve systemic issues. She's received both her Bachelor of Arts and Master's of Arts degree in clinical psychology from the University of Texas, El Paso. I'm really excited to bring you this interview. Enjoy the show.
Thank you so much, Diane, for joining us today. We are very, very happy to have you and to learn more about your work. And so we'd love to start off with getting to know you a little bit more. And of course, if you could, tell us a little bit about yourself, but also how your work really impacts our primary care system here in Texas.
Absolutely. Thank you so much for having me. I'm glad to be here. A little bit about myself. I am a second generation Latina and came from El Paso, Texas, which is a predominantly Latino community. Received my undergrad and my master's degree in psychology at the University of Texas, El Paso. Moved to Houston about 10 years ago, but I was always interested in mental health and addiction and recovery because it is very taboo and a topic that our community doesn't talk about very often. I saw it in my own family with losing an uncle to cirrhosis and having another uncle in and out of rehab. And so addiction has always played a part in my family. The way I really got into healthcare, in the broader sense of the word, is because I wanted to be a voice for people who uh, couldn't find their voice. I always tell the story about my grandma who was predominantly Spanish speaking at a clinic, and she was fasting and she was by herself, and they lost her paperwork, and she ended up passing out and having to go to the hospital. And from that moment on, I swore that I was always going to be her voice and take her to every medical appointment that she needed. And that really is at the crux of my passion. I found her in a vulnerable state and never wanted anybody to feel like that about themselves or about any of their family members. Um, so all this impacts my work right now with the Council on Recovery. We've been around for about 75 years plus, and we're really the place to start when it comes to addiction and recovery. We do prevention, we do intervention, we do treatment services, all the way through to recovery support. But the great thing about the council is that a couple of years ago, we started an initiative called the Center for Co-occurring Disorders. This initiative is really focusing on the fact that addiction is a part of people's lives and it is a part of their well-being. We define addiction as a chronic medical disease that should be treated that way. So this center is really focusing on helping primary care clinics and spaces to acknowledge that, really understand that acknowledging an addiction is going to help somebody's diabetes or somebody's HIV or somebody's blood pressure or somebody's depression or somebody's anxiety. Right. So I think it's been full circle I've been in the healthcare space before. I've worked for federally qualified health centers. I sit on a federally qualified health center board. But it really is a place for me to have to advocate.
Yeah, thank you. Thank you for sharing all of that. And it's so I love hearing people's why. And it really feels like we got to hear your why for entering this field. Would you mind, in your own words, defining what primary care means to you?
Absolutely. Primary care to me has always been the place to start. The doctors with the most knowledge, the ones who see it all. Um, Primary care is one of, I would say, probably in my book, the most important provider relationship that you'll have if done right.
Yeah. At our summit, which I believe you presented at, actually, we had this video of three different patients getting to share their primary care story, what they really appreciated about their primary care physician, the primary care system, but also what maybe was lacking. And what we kept hearing is they really wanted a relationship of trust. If there wasn't that bi-directional, mutual, relationship of trust, then there just didn't seem to be an open maybe dialogue, and maybe there was even hesitation to fully share, right, what that person was truly wanting to seek that clinician for. What do you feel, or I guess what challenge are you currently working on, and how is that related to primary care, or do you feel like how can primary care help you maybe alleviate your current challenges that you're working on in your space?
Absolutely. Well, I mean, there's quite a few challenges in the behavioral health space, right? One, I'll start with the behavioral health workforce shortage. We do not have the amount of individuals we need to properly screen, assess, treat the population. It was said before COVID that we were going to be in a 50% deficit by 2030. And now with COVID happening, we're in much more of a deficit of people not even, wanting to come into this field anymore, because it is a very difficult field to go into. So I'd say that that's the one of the biggest challenges, but how that bleeds into primary care is that if we can train individuals to understand and acknowledge addiction as a chronic medical disease, then perhaps we can have those screening and assessments done in that type of space. Which leads to the second challenge, which is the education and training for providers and ancillary staff. A lot of times when we go around working with federally qualified health centers or primary care clinics, we get the response that I would love to screen for it. I would love to acknowledge it. I would love to help this person, but there's not enough resources out there to send them to. But that's where we come in, right? We don't want to be a secret. We don't want the stigma to be perpetuated. We want people to come to the council. We want people to go to their local OSARs, which is the outreach, screening, assessment, and referral programs throughout the state-funded HHSC. We want people to utilize them as resources. We want them to know we're here. So it's also about educating and training those staff and really getting them to understand that. But even before that, a challenge that we've seen is that the amount of education that providers are receiving in med school is abysmal when it comes to addiction, right? We are now working with U of H, Go Cougs, on with their med students on how to identify, how to screen, how to work through their own bias about addiction and recovery, because that's the first step. Substance use is still so very much stigmatized, and until we can eradicate that, we're going to be in the same place a little. So we're helping young providers, young clinicians learn the language on what to use and what to say, So those are a couple challenges I see, ways that we can have primary care help. Reach out, ask for education, right? We've done a pilot. Yes, we did present at TPCC. Thanks for having us. Great conference, by the way. But we did present, and we presented on a pilot that we've been doing with an FQHC that we started to get them to screen and then streamline the services to us. Within 6 months, we had already screened over 1,000 individuals. Now, I'm not going to sugarcoat it. Not every one of those 1,000 individuals is ready to go into treatment, but they got the information now and they're one step closer, right? And research shows if we shared this with our presentation as well, if we can get to the point where the addiction hasn't caused the changes in the brain chemistry, et cetera, if we are working on prevention, where individuals are on a slippery slope, maybe they're acknowledging, they're recognizing they're at a mild level of substance use, then we can reverse that and we can get them to not fully go into full-blown addiction and even worse, withdrawal and dependence. So if we can educate primary care physicians, we are willing to go out, we are willing to do virtual trainings. If we can train one person to ask the question and then know where to refer, then we are doing our job.
Yeah, that's amazing. Curious, actually, as you've worked with primary care clinicians, so it definitely sounds like, they're open and they want to be educated and they want to know, right, how to counsel their patients and then where to send them. Have you ever experienced any, sort of hesitation maybe where the clinicians are hesitant to bring up this topic? And I ask that because, one topic that we at the consortium are diving into is firearm safety and, how we can create a clinical intervention for, primary care clinicians to talk to their patients about it if there is a firearm in the house, really reducing the stigma and try to normalize that conversation, especially if there are young kids around, let's say, really focusing on the safety part of it. But, of course, that also requires that relationship of trust, a culture of trust and how to not just help the patient feel comfortable, but we're finding that, also helping the clinician feel comfortable having that conversation. And so curious if that's been an experience in your space as well.
Yes, you hit the nail on the head. And I love that you guys are working on that initiative and maybe we can come together to see how our best practices can be leaned toward a different topic. But provider comfortability, like if they are comfortable in asking the question, that actually has an effect on whether the people will get treatment. So we started out with, when we were doing focus groups, we had a clinician who happened to be an OB-GYN, and she was like, I'm not going to ask about weed use. But we're like, but your patient may be pregnant and it may be not just harmful for her, but for the baby. And she was just like, I'm just not. I don't feel comfortable asking the question and I don't feel comfortable not knowing where to send them. So we are definitely seeing some reluctance and some hesitancy. But that's again where the education and training come in. We have to educate and train. One of the first 5 slides that I have when I do educations on substance use, addiction, and recovery is the 3 top definitions of addiction. And according to the American Medical Association, according to the American Psychiatric Association, and according to the American Society of Addictive Medicine, substance use addiction is a chronic medical complex disease and should be treated as it, right? So trying to get people to see it in a different lens is really, really important. And to be honest, there's a couple ways that we also get people to see that, and that's if there's a financial impact with individuals using substances, but then there's also a humanistic impact. So wherever somebody lands on the spectrum of whether they're more humanistic, whether they, are more worried about their financial place, we have 210 people dying a day from overdoses. Is this something we need to address, right? That should tug at some people's heartstrings. On the same token, for financial, we in the US spend more money on addiction, whether that be in hospitals, whether that be lost wages, whether that be in rehabilitation places, more than heart disease, more than diabetes, and more than I believe it's hypertension combined. Combined, it's a huge number. Um, so there is reluctancy, but I'm half glass full type of person. There's always a solution. I think when people are educated and when they're trained and when they understand, and maybe when they hear that personal story about people who have suffered, maybe that makes that impact for to get them to change their mind.
Yeah, that's very helpful. It's very I love all the work that you guys are doing. And I actually really love this next question that we have, which is if you had a magic wand, what is one change you'd make in the primary care system? And you touched on, medical school curriculum a little bit. And so curious if it's that or, what that first next change would be to maybe help then with a bit more integrated system.
Oh, you know, I feel like it's like, oh, I'd solve world hunger, like that type of question, right? I think I would solve the stigma piece. I wish people could understand that addiction is not a moral failing, that people who use substances, there is a story behind it and there is a person, and I wish I could eradicate that. Um, one for the care of the person, but for the future of our community, because one person treated in addiction can help a whole family. So yeah, I think I'd eradicate the stigma.
That's very powerful. Thank you. Thank you, Diane. This has been really wonderful to get to know more about you and your work. And of course, people will be able to contact you if they want to connect with you for questions. And they might be a primary clinician themselves, and they might want to reach out to say, hey, I want to learn, I want to know where I can send my patient. So thank you, thank you, thank you. We really appreciate your time.
Thank you. Thank you for doing this and inviting me.
Thank you so much, Diane, for that very informative interview. I think many of us will want to reach out to you so that we can learn more on how to educate our primary care clinicians and, of course, continue the integration of behavioral health into primary care. If you have any questions for Diane, her email as well as the website to her work is listed in the email from which you got this recording. And of course, if you have any feedback, questions, comments for us, we'd love to hear from you. If you have guest speakers that you want to recommend to us, or if you want to be interviewed yourself and talk about your great work, we would love to do so. This has been Texas Primary Care Consortium's monthly Monday Primary Care Talks. Until next time.